Hello, everyone, and thank you for joining us. This is You Can Thank Us Later, the podcast/webinar series from CG Moneta, the nation's premier cost reduction firm. Today, we are honored to have with us Jared Bongold. He is a healthcare strategist and benefits expert at the Insurance Office of America. We'll be touching on the exorbitant cost of healthcare and kind of touching on some of the pain points and some of the reasons that we're seeing these inflated costs. How you doing, Jared?
I'm doing great. Thank you for that introduction.
Excellent. We appreciate you joining us today. One of the things that we want to focus on, because this has been an issue for years now, is the fact that there's 157 million people that, or 90% of workers that are employed by a firm that offers health insurance benefits. Yet, benefits seem to increase on average 10% a year versus the actual cost of 2%, and real costs increased. Can you kind of fill us in on why and what are some of the options that employers out there have for cutting those costs and getting things more aligned with reality?
Yeah, absolutely. And that 2% figure is from the Bureau of Labor Statistics. So what that's saying is the cost for hospitals and doctors to deliver care is going up 2%, 3% a year. Yet somewhere along the line, the health insurers are passing on a 10% increase on average to employees and the employers. And so you bring up a great question. Where is that spread coming from and what's the cause? So at the end of the day, it comes from a variety of sources, and we'll break into each one of those because there's three to four categories really that you can break that down into. The hospitals, for instance, and not-for-profit hospitals these days regularly have $10 million annual comp packages for their executives. The CEO pay at the 8 largest insurance companies has more than doubled in 2 years. So someone's making money, and it's not going to the provider. It's not going to the doctors because their compensation is relatively flat. The workers is relatively flat. So the money is coming out of employees' pockets and going to the blob, the healthcare system blob. And where a lot of our strategies come into play is if we can untangle the blob a little bit and pull some of the good pieces out and leave the rest in the mess and just avoid the mess, that's what where savings ultimately come from.
That makes sense. How do you go about doing that? I mean, it's one thing to say we're going to avoid the blob or the mess, and being able to actually not just conceptualize it in your mind, but actually recognize it. How do you do that?
Yeah, so the U.S. has some negative reputations compared to our peer companies when it comes to healthcare, higher obesity rates, and especially their higher chronic conditions like diabetes and hypertension. But at the end of the day, we don't go to the doctor in America. We don't go to the doctor any more than our European, Australian, and New Zealand peers. We don't. We access drugs about the same rate. We just pay more for a lot of these things, and we have a lot more administrative costs in the system. And I'm not an advocate for using their systems. It's more of how can we get the best of both worlds, because we do have an extremely high performing healthcare system in some areas, and we have an extremely low performing system in other areas. And right now, what it essentially comes down to is market failure. So right now, if you were to go to your insurance company's website and do a provider search, you would not be able to tell all of the quality differences or many of the cost differences between, let's say, two doctors to perform the same procedure. However, statistically speaking, 50% of doctors are average or below.
That's a scary thought.
So how do you know that you're going to a above average or a below average provider? And that's not to say that every physician or every provider is below average in all areas. So again, it's a mismatch problem. How can we match your care that you need with the best available provider for you at that time? And we deliver solutions to do that. by solving the match problem.
Let me ask you a quick question, not to cut you off. So,
Yeah.
all right, I have a family member right now that's got cancer, right?
Mm-hmm.
So when you're looking for, and some of these doctors, obviously, it's a life or death situation.
Mm-hmm.
In this case, whatever doctor that's going to treat, whatever oncologist that he chooses, it's almost like a roll of the dice. Whatever they're
Absolutely.
gonna, put them in, like line them up with. How can you change that? How can you make sure that my family member has the best doctor, or
Mm-hmm.
has at least the option to go to the best doctor, rather than just being handed what they have and having to go with it?
Yeah, that's a great question and a great point. It really is a roll of the dice, and some level, every party is evaluating, doing the best they can. So I think as we go through this, we'll answer that question in more detail. But let's kind of start from the top, which is, I have a question for you, which is, do you care more about your own business and your own revenue, or your own family financials and health outcomes, or do you care about the company down the street or the people down the street?
That's number
Right.
one.
Yeah, you care about your own circle.
Absolutely.
And the reason why that comes into play is the health insurers aren't designing their programs with your family in mind. That's not to say they're disregarding your family or they don't care about your family. It's just that's not the prioritization. They're renting a product to the consumer. But in the United States, we have a great thing called ERISA, the Employee Retirement Income Security Act, that allows employers to say, I want to own my own healthcare plan. So if companies avail themselves of that, instead of renting a product that's designed for the health insurer to make money and have a sustainable business, they can design a product that they own and is customizable to their population, their workforce, their needs, their locations. And by doing that, we can align all of the incentives, because there's a natural antagonism between the insurer and the patient in some areas in our current system. It doesn't have to be the way, that's just the way it is right now. So for example, if a carrier owns their pharmacy benefit manager, and then the pharmacy benefit manager owns the specialty pharmacy that's prescribing the drugs, and they're passing on those claims costs to the company, to an employer and their employees, well, it comes time for a pre-authorization, and the pharmacy benefit manager says, wow, our specialty pharmacy would make a lot of money if we filled this prescription. I'm not saying they actually say that, but it's in the back of their mind. That's why we've seen pre-authorization rates be triple what they should be in many cases. And that's not, and people, I think, look at that the wrong way, which is when you're denied a pre-authorization in an aligned environment, it's not to say that you can't get the drug you need. It's that drug actually isn't the drug you need. That's why we're denying it. And because the way a lot of this stuff works is the more expensive drug should be tried later, because usually it's more expensive because it's newer. So unless it's revolutionary, and right now our track record of silver bullet revolutionary drugs is they don't come around very often. So it's very incremental, and there's costs in the form of side effects to those changes. So, we kind of went down a rabbit hole, but that's really what it comes down to, is aligning the incentives, because good patient outcomes lead to lower costs in the long run, and finding the right providers is the key to that, and keeping your workforce healthy and being able to live their lives comfortably is a priority for the employer and the employee.
Yeah, that's absolutely no question about it. And from an employer standpoint, having a robust benefits offering also creates a situation where you keep the employee for a longer period of time, especially in today's society where it's impossible to hire. Everybody's hiring and nobody can find any labor. From an employer standpoint, I'm really interested in one of the things you just mentioned. Either going to the insurance company and letting the insurance company profit, or me as a small business owner actually designing my own plan for my employees. Is that super expensive? And aren't I going to spend a lot more money doing that than if I went to a plan? How does that work?
So no situation's universal,
Mhm.
but generally speaking, designing your own plan, and you're not alone. There are ways to aggregate smaller employers together. And the first thing I would say is we've addressed, well, if you want to own your own health plan, you want to set it up with aligned incentives. And right now, the biggest challenge, first and foremost, is getting the data to know what your risk profile is. Most groups with under 100 employees get almost virtually no data on what's affecting their population. And in some states, that can go as high as 200 employees. And the data that we do get is delayed. It's not in real time. It could have been from 9, 10, 12 months ago. It's like, well, that doesn't really help us right now. And yeah, you're right. That was a high cost claimant. That was a $100,000 procedure. Oh, by the way, the Medicare reimbursement for that was 18 grand. So we could have paid 30. Everybody makes money, and we're in the same boat. But is it still a high cost claimant? Not really. So the data transparency is the biggest first step to finding out if you're well positioned right now. In the long run, I think almost every employer would be better positioned by owning their own health plan if they're willing to invest the time and the money. And when I say that, I don't mean we do a lot of the legwork, but an employer has to make decisions for this to work, and has to understand why we're asking the questions. And so again, that goes back to the data. If we say your population has 7 different cancer cases, so like you mentioned cancer earlier, and they're all different. What if we can engage with a cancer specific solution that allows for second opinions, matches the diagnoses to the best providers in the country? Because there are hundreds of different kinds of cancer, and there might be a handful of doctors that are well versed in that specific diagnoses. So don't go to a cancer generalist, go to a cancer specialist. Let's get you treated. Let's get it solved and give you the best chance possible to recover and go into remission. And does that cost more money? Sometimes. So it's not always about the money. In that case, it's about the outcome. But I think if we're implementing those types of programs, we're going to save money on the more run-of-the-mill things like colonoscopy, CT scans, MRIs, which more than make up for the increased cost of those 1 in 100,000 type cases.
That makes sense. I never thought about that. You know what stood out before, and I can't get my mind away from it, is the fact that over the last 2 years, 8 of the biggest insurance companies, their CEOs, executives, their compensation doubled. That's crazy. And then, all right, so let's look at that. The average worker, right? Their share of family premiums. I'm sure they've increased. Even going back as far as 2010. So talk to us a little bit about premiums in general and the ever higher deductible that seems to just go through the roof every year to the point where it's almost not affordable for middle class families. Can you kind of tell us a little bit about that?
Yeah, absolutely. So there's a couple different things, but I think 2010 to 2020 is a great 10-year time frame, because 2010 is right after ACA was passed, but before any of it was really implemented. So if we're tracking the new regulatory regime of the Affordable Care Act, the results aren't great. So right now, the share of family premiums has increased 40%. The employee share of family premiums has increased 40% since 2010. In 2010, only 20% of workers at a small firm, which was less than 200 employees, had a $2,000 deductible. That was 3% of employees at large firms. Now it's 42% of workers at small firms, so it more than doubled in the share of workers, and 20%. So that's an almost 7-fold increase. So what we're seeing right now, beyond the fact that premiums have gone up, the costs of care have also gone up, because the employees, they're pushing the costs onto the employees. So the insurance companies are spending less on smaller claims because of these higher deductibles, but it hasn't affected premiums. So when the insurance companies are saying, well, look, we can drive down the cost if we just create what's the word they use? Consumerism. Consumerism in healthcare. Okay, well, we already talked about market failure. So there's no such thing as consumerism when there's market failure. There's not market failure in the price of oranges. There's not market failure in,
True.
at most of the things at the grocery store.
Mhm.
There's massive market failure in healthcare. So introducing consumerism doesn't do a thing in the traditional sense. So the other thing you mentioned or that you didn't mention, but it plays into this, is the role of a doctor, a primary care doctor. Primary care doctors are the lowest paid and have to spend more time on paperwork per patient than anyone else. It's the average primary care visit, I believe, is under 10 minutes of actual face-to-face time. They're seeing 30 plus patients a day just to make maybe $100,000, which, hey, don't get me wrong, $100,000 is a lot of money. But when you have a specialist that's making $450,000, seeing 2 to 3 patients a day, doing a handful of surgeries a week, working 30, 35 hours sometimes, whereas the primary care is pushing 60. That seems misaligned with what's best for the overall population and how to drive down costs. So where we've seen a lot of really good success and where this plays into the deductibles is that's a misaligned incentive. If you have to pay $100 every time to go see your primary care doctor on a high deductible plan, you're not going to go see them. But if you want to just call the doctor and ask a question, they're answering that out of the goodness of their heart, because a lot of times the insurance contract doesn't allow for any form of reimbursement for that phone call. So it's essentially charity care, and they're doing you a favor. And meanwhile, we have direct primary care systems and payment models that allow providers to make more money than they're making now and spend more time with patients. That's an aligned incentive right there. So the number of things we can catch when we get rid of the barrier to talking to not a doctor, your doctor that you've selected, that you trust, that has access to your data, and then we can pair that with things like home monitoring. You don't need to drive to the doctor every time for a follow-up. They say, okay, here's what we're going to look at. Wear this device or do this every night. We're going to get a much better data point than this appointment on June 29th, and then we'll see you again in 3 months or 6 months. And then now we have 2 data points covering 6 months, and we're supposed to make major medical decisions for your healthcare off of these 2 data points. What if we just track that every day? You come back and then we have a phone call in a month and say, all right, we have 30 data points now, and yeah, things are trending down. I think we're okay. We don't need intervention, or no, this is progressing. We definitely need some sort of intervention here. So the outcomes change, the cost structures change, and healthcare improves in that model.
Yeah, that makes sense. All right, as a business owner, then, when we're looking at the costs, we know as a consumer what it looks like. We've all experienced it. But why don't you take us through your process? What is your value proposition? And as a business owner or as an executive, why am I sitting down in Jared's office to discuss what you can do for my company?
Absolutely. So where I mentioned earlier, the kind of the 4, we'll call it 4 challenge, is the parties to the challenge. So we mentioned hospitals and insurance companies with their rising executive compensation and just worsening value proposition. We talked a little bit about misaligned incentives on pharmacy. So those are 3 of them. And one of the 4th ones really is the traditional broker model. So a lot of brokers, they represent themselves as if they're a buyer's agent working for the employer. And while there is some truth to that, almost universally in the traditional model, they are paid like a seller's agent because they're paid by the insurance company. There are retention bonuses, new business bonuses, incentive trips, all of those things, which they've done psychological studies on doctors about how they prescribe based on which medical or pharmaceutical reps spend the most time in their office and take them to the most dinners and golf outings. So if it's happening there, it's almost certainly happening on our side of the fence. So that leads us to the 4 parties. It's the hospital systems with their consolidation and favored tax statuses, the insurance companies with their bundled silos where they make money, where they set up a plan to make money at each step of the way. the pharmaceutical companies and the pharmaceutical benefit managers that have a bunch of backroom deals where they're taking large rebates by filling prescription A. Meanwhile, prescription B made by a competitor is a better drug and it costs less money, but that one's not on the formulary because the PBM doesn't make a kickback on it. So we've seen these situations, and it's bad, but there's a way to undo it. And then it comes to that fourth party, which is the traditional broker model. So if you go with a traditional broker, you're going to get traditional results. So you gotta go outside the box. And I've talked to a number of companies. They say, well, I don't think we're ready for this. Well, you're not going to know you're ready until you take any steps. And if you stay exactly where you are, you're going to be exactly where you are in the future. You have to move. You have to do something. And where that comes in is what we call healthcare strategy or healthcare management strategy. So we focus on three things. That's transparency, which is what you're paying for, why you're paying for it, to whom you're paying for it, and then when you're paying it. So fully disclosed payment terms, for fully disclosed payment methodology, and contracts. Sustainability is as the employer, is the plan design and the health plan that you own designed to last over the next 3 to 5 years if we change nothing? And can we adapt it as needed? And then dependability. Dependability is key for the employees and their families. When you need healthcare, can you access it? And is it set up to where you can reach those best-in-class providers that are going to provide better health outcomes, and you're going to know that it's not going to break the bank? So those are the three tiers. Now, I think when we've talked last week or the week before, we were discussing how to drive down that 30% decrease in cost. Well, right now, inpatient hospitalizations run about a third of costs. Pharmacy runs about a quarter of costs, and then ambulatory or outpatient surgeries are about 20%, and then physicians' visits are about 15 to 20%. So we've found that in most traditional health plans, each of those areas can be reduced between 15 and 30%.
Wow, that's a big number.
Yeah,
that's a very big number.
Absolutely. And some of the times we increase one area to drive, like primary care is a great example. We spend more on primary care to drive down long-term costs. And we have a lot of data to show that even if costs go up in year one under a direct primary care model, they come down in year two and three significantly. Because what we get hit in year one oftentimes is people that delayed care because of the barriers to entry. And find diagnoses that had been missed in years past. So it's all kind of hitting at once. But then those people are healthier and happier, more productive in years 2 and 3, and we have less issues. And then it just compounds from there.
No, that makes sense. Is there a specific size company you specialize in, or a specific vertical, or do you work with just about everyone?
We can work with just about everyone at IOA. Personally, the majority of my clients are going to be between 50 and probably 500 employees. And then I have partners that can extend beyond that and below that are more in tune with those market segments. And the biggest thing though is, even if we can't execute 100% of the ideal plan. So I use the analogy, the old rotary phone versus, with the cord and all of that stuff, and your iPhone 12, right? So we didn't go from the rotary phone to the iPhone 12 in one day. That took decades. So what we're talking about is maybe let's get a cordless phone, maybe let's get a car phone, let's get a old flip phone, and as we move along that continuum. Because pretty much any size employer can move a little bit. We may not be able to do the full-blown direct network where the employer has contracts with the hospital systems in the area, has direct contracts with an imaging center, has their own clinic. a 7 employee group's not going to be able to do all of that, but they can do some of that by working with with a care aggregator, by working with a system that aligns the financials a little bit better. There's ways it can be done.
That makes sense. Do you charge a fee to come in and review everything in terms of current setup versus potentially what you could provide? Do you charge an hourly rate? Is it a complimentary service? Tell us a little bit about that.
So that's a great question. Our overall goal is to be a replacement for your traditional broker model. So initial consultations are free. That's part of the job, because some of it is you're not just evaluating us, we're evaluating you, and we need to make sure that we're on the same page. There are times where we've talked to prospective clients and they say, we're running into all these issues, and we say, okay, well, we've identified them but from a compliance standpoint, we need you to execute A, B, and C. And they say, well, I thought you were going to do that. I'm like, well, we legally can't, so we're not going to. And they draw a red line. I said, well, we kind of have to draw a red line too. But that's very much the exception. Typically, what ends up happening is we say, hey, here's what we think we can improve, and if you buy into our philosophy and think it's the right fit long term, then let's make a change and start working together. We're going to take over your existing program, really, because any review is surface level. Then once we dive in and start administering the plan with you, we're going to get a really good feel for your employee population, what their needs are, what the challenges feel like on a daily basis. And then we say, okay, these are the changes that are going to solve each of those line items. And then we start talking about the different methods for cost containment.
That makes sense. How long does it take though? Like from beginning to end, let's say you're engaging and then you're administrating. How long from that point do you have, let's say, your version of the perfect or ideal situation in place? What's the typical time frame look like?
Yeah. So under my philosophy, when you own your health plan, it's an ongoing process. It's not a set it and forget it 90-day sprint to your renewal. So let's sit down and talk. What are you running into right now? Ideally, we're in 6 to 9 months before the renewal, and because that gives us more time to stand in your shoes as the client and see what kind of issues you run into throughout the year. And then as we get closer to that renewal timeline, that's when we start looking at the cost containment strategies and what we can do. Now, have we taken plans over 30 days prior to renewal and it's a mad dash? Yes. And we're happy to do it. Just we're most effective earlier. And because in an ideal situation, our process takes 2 to 4 weeks to do a thorough review, from compliance, from plan design, contribution strategies, financial impact, and translate that into a deliverable report.
That makes sense. All right, so we're coming up on the wrap up time, but I think it's important, 2 things. One, that anyone that's got an interest in reducing their overall cost of healthcare benefits, being able to contact you. So can you provide all your contact information?
Yes, absolutely. So if you want to do something about probably your second, third, or fourth largest line item for most companies, you can reach me on my cell, 727-565-7073, or you can email me at Jared, Jared, .mongold, MONGOLD, at iowausa.com.
Perfect. Excellent. And again, don't hesitate to reach out to Jared. He's by far one of the most impressive young men I've ever spoken to when it comes to health benefits. Half the time I'm just gonna blown away with first of all, everybody knows some of the issues that are in that particular area, but your ability to not only just grasp it, but to articulate, so somebody understands the approach and what you see as the answer is incredible. So you do a great job. Very impressive. Vinny, did you have anything you wanted to add, Vinny?
No, I mean, Jared, I appreciate you taking the time to meet with us today.
Absolutely.
I think you provided a lot of helpful information out there, especially in this challenging environment every business owner is dealing with right now. Again, appreciate your time. A lot of great insight into what's going on out there and what we can do to kind of help control costs. Appreciate it.
Absolutely. Thank you very much. And as they may be hearing, benefits can be a huge differential when it comes time for attracting and retaining talent, which I know is a massive challenge right now. So, So sometimes it could be your benefits package that's the difference maker.
Amen. No doubt about that. Well, thank you, everyone. We appreciate it. This is You Can Thank Us Later, a podcast by CG Moneta, business cash flow and other inappropriate topics. Dan Cobell, managing partner. Vincent Gargione, my fellow managing partner. Jared, thank you. We appreciate it and look forward to talking to you again in the near future.
Thanks, guys.